Hello, we're the multidisciplinary team from Cwmtaf Morgannwg Health Board, and our project's called Children's Skin Matters. We're made up of the Community Children's Nursing Team, Paediatric Physiotherapy, Paediatric Occupational Therapy, and our Tissue Viability Nursing Team. Our background is that we identified that we had some ongoing issues with children, young people with complex needs, and whether or not we as a team were giving due regard to their tissue management whilst also looking at their equipment and other health needs. This project started in 2019, pre-COVID, and we were at quite a leisurely pace, sort of starting to talk about what we needed to do. And then COVID-19 hit and all work streams in the NHS stopped. And we started actively risk managing our high risk children in the community through the first wave of COVID. And what we identified there was we suddenly saw a massive increase in reporting of tissue viability issues with children. So we went from having approximately 2 cases a year to identifying 4 different young children with single or multiple areas of skin breakdown in the first 8 weeks. So we had some questions to ask ourselves about, were we seeing our own pandemic? Had we previously been underreporting? Had we been blind to what was going on out there? Had we underestimated that school and other settings were doing essential work to keep these children and young people well? And do carers and know what to do, because they're now fully in control, their children are not in school, health services are very much a more distant place from them, and actually we made a lot of assumptions that parents knew how to manage their children, how to manage their children's skin, and how to manage their children within their equipment. From there, we identified that we did need to develop and move on with this project, and we re-kick-started and developed some aims around what we wanted to achieve. And it's a very broad aim and covers education, covers early identification, management, escalation, intervention, and it covers working in schools, working with parents and families, working with other carers, and also upskilling healthcare professionals that support these young people. So it became massive, really massive, big aim, and how did we chunk that up into some appropriate objectives? So we chunked it up into what we expected from the healthcare professionals in relation to their roles, what we thought the training packages needed to be for families, carers, and school staff, what written information was out there for families and carers to provide that education that they required to help them prevent and identify pressure ulcers, and what kind of pathway did we expect there to be in place for professionals that was robust, evidence-based, and would support the management and delivery from healthcare professionals of both a child's postural care management, but also of their skin care. So it was a big ask, and we've chunked that up for ourselves as part of our Bevan Exemplar. We haven't completed it all, but what we have done is developed a lot of resources, and we're well on the route to our completion. One of the key things we have completed is a video that's just 4 minutes long for professionals and or parents, or anybody who is interested, who Googles out there what children's skin, children's pressure, what they get, what resources might be there for them, that would allow them to just get a taster of what we would be saying and why children's skin matters.
It is vital for children and young people with complex needs that their posture and skin is managed and postural deterioration and skin breakdowns avoided where possible, as the impacts of these can be significant for the child or young person and their family. It is the responsibility of all people surrounding the child young person to support their postural needs and minimise the risk of skin breakdown. As you can see from this slide, the expectation should be on everyone to manage, support and identify any issues to ensure optimisation of posture and skin care. Postural management refers to the use of any technique or equipment to minimise impact of postural abnormality and enhance function. As you can see, it should encompass a person's daily life across the full 24 hours. The focus needs to be on every minute of the day, as we leave our children at greater risk of deformity and skin breakdown if only managed for certain periods. The impact and consequences of poor postural management can be significant for the quality of life of the child. This slide highlights some of the identified consequences, ranging from pain to issues with digestion and respiratory function, and not forgetting the impact on skin integrity. Skin breakdown can have significant consequences for the child, young person and their family.
There are three main causes of pressure ulcer development. The first is pressure, where a child may be unable to move or change position regularly, resulting in a build-up of pressure. The second is shear, when there may be an inappropriate sliding in the child's bed or chair, or where there is gravitational force between the bone and tissue. The third is friction, where there is movement between the skin and an external surface, for example, the bed or the chair. This slide highlights the most common areas where pressure areas can occur in children and young people. Some of these are more obvious than others, and some may be missed, for example on the ears, the heels, shoulder blades or inner thighs. The SKIN acronym can help us to assess a variety of factors. Taking the opportunity to look at skin whenever we can will ensure the health of skin is regularly checked. These opportunities can be throughout the day or night, depending on the needs of the child or young person. Documenting your observations is good practice in order to effectively compare. Regularly reviewing the surfaces the child or young person is sitting on, lying on, to ensure the surfaces continue to help protect the skin, reduce the risk of pressure damage and are not causing damage to the skin. Regular movement throughout the day or night can help prevent potential skin breakdown and damage. For children and young people that rely upon continence products such as nappies or pads, vulnerable skin areas that are enclosed by these products can be prone to skin damage and breakdown. Therefore, regular review and use of barrier creams are important. It is also essential to consider good nutrition and hydration to ensure the skin is as healthy as it can be. It is important to remember that posture and pressure go hand in hand. Collaborative working is essential with the families and healthcare professionals. An individualised plan of care should be developed which incorporates a 24-hour postural management plan. In addition, documentation and regular skin inspection must be completed on the child's repositioning skin inspection chart. Posture and pressure management are not separate. Everyone needs to take responsibility for the correct and safe management of posture and pressure in children and young people.
In summary, our work is set out to develop a shared collaborative pathway, promoting a shared language with clear escalations to effectively and safely manage our children and young people's skin. This pathway contains robust training packages for all, as it is everyone's business, as well as skin inspection checklists and individualised postural management plans. Our message is clear: children's skin matters.
With regards to key outcomes of our project to date, we have developed and begun delivery of 2 collaborative training packages to increase the knowledge and skills of nursing staff, therapy staff, parents and school staff who support and care for this complex group of children. These packages focus on 2 key areas. The first focuses on pressure ulcer identification and management, and this is delivered by qualified nursing staff. Our second package focuses on the importance of 24-hour postural management and is delivered by therapy staff, both physiotherapy and OT. Feedback on early training sessions has been positive, as you can see, and this is an ever-developing aspect of our project.
Alongside the training, we have developed a package of resources to support healthcare staff, school staff and parents in identifying and meeting need. This includes information leaflets, positional passports and skin checklists, to name just a few. One of the major key outcomes in this is the development and embedding of a shared nursing and therapy pathway that links skin surveillance and postural management. Historically, this has been very much a balancing act, which has often tipped one way or the other. This new pathway promotes a shared language and encourages a higher level of collaboration to improve the management and outcome for this group of high-risk children.
So as a team, we faced a number of challenges. Due to COVID, face-to-face teaching and meetings were suspended. This impacted on planned teaching and meetings. Initially, it was a challenge to access our online platforms to attend meetings together. Also, some team members were redeployed during December to March. That impacted on the development of our information sharing. In addition, some team members were moved into different roles within the organisation, which again impacted on their availability and their capacity to be part of our group. However, despite these challenges, we've worked together collaboratively to improve the outcomes for our children and young people.
In relation to our next steps, we did identify that will it get worse before it gets better? So as we increase awareness in all arenas, will we see increased reporting? We identified that we potentially saw underreporting in children and young people in relation to skin damage. And as we increase awareness, that we will see increased reporting. And that has an impact for us as a health board, because that's a key performance indicator to Welsh Government. We also were clear in our next steps that some of the resources that we have put out there onto the Bevan web pages are resources that we felt would not create any fear for parents if they clicked on them to look if they had concerns about their child's skin. But they weren't necessarily all of the resources that we have developed. And we have developed a big suite of resources for professionals as well as what we've put to the Bevan web page. How are we going to roll out training packages across school and to parents is an interesting concept with COVID, in as much as we have a population where digital literacy and digital poverty are an ongoing issue. So we are looking at how can we do that with some of our special schools and them enabling us and enabling parents to link into that. And we think there will be real strength in that, as both the carers of that child through the day and the parents are receiving the training at the same time. Also, how do we continue upskilling our own paediatric physio, nursing teams and occupational therapy teams in the identification and robust management of children with either postural needs and or skin damage? Our multidisciplinary protocol, we're continuing to add to, and the ratification and adoption of that will be a key aim through the next 12 months. We're hoping that we will also be able to upload all of our resources to the Health Board's externally facing pages, including the video that we've put on the Bevan web page, and that may be something that will be available to parents either on the Health Board's YouTube channel or through the Health Board web pages. We're looking at the development of exemplar reports to publicise the protocol and resources across the Health Board. And how will we know that any of it's had any impact will be in the audit of nursing and therapy records against the protocol later, to say, are we identifying more children or young people, and are we managing them better? Are we seeing a quicker resolution? One of the other key areas has been identifying that new Band 5 nurses coming into paediatric nurses come in with a Paediatric Journal of Excellence. And how do we ensure that this training and this package is part of that Paediatric Journal of Excellence for all new starters and new paediatric nurses? Those are our key next steps. And as fast as we think of the next thing to do, we'll add another 3 to the list, as that's the nature of any evolving sort of programme or protocol that we develop. Thank you.
We will now have a Q&A discussion. How have you managed to get the multidisciplinary team engaged with this MDT project?
I should ask the team to answer that, because I think that's maybe why have they stayed engaged, rather than me saying, how did I engage them? I think engagement for me was about creating pace, purpose, and passion. So if you've got people who've got a passion about things and a purpose, so they understand why they're doing them, you can create pace. But if you don't have the first two, it's very difficult to have pace. That would be where I would say, once you've got people who care about it and they understand what you want to do, they will come with you. I think the question of how have they stuck in that long is over to the team. So I'm going to put that over to them to say, how do they engage?
I think as individual services, I think we were all coming against the same obstacle all the time. And we were kind of starting to have conversations about why we hit this obstacle every time and not really thinking or talking or trying to resolve it kind of collaboratively, really. So I think it's been something that's been an ongoing conversation between us individual services. And I think it was just the coming together meant that we knew we'd be able to kind of knock that obstacle down. And I think that's what kind of kept us focused.
Yeah, and our key role really is to, drive down the avoidable harm that we have started to see an increase in, or, especially over the last 2 years.
And for me as well, it was the keenness to make sure that that responsibility was shared with others within each of our teams, because it was trying to uplift the profile of the roles and responsibilities of everybody that worked with those children and young people. Plus, it was the fact that Donna's quite a phenomenal force to reckon with as well.
In hindsight, is there anything that could have sped up or enhanced your project?
I think if I was saying that purely from my own place, what I would have said was having our lead person to link with was actually external to our health board, and having somebody internal to our health board as your champion. I would say when it's a clinical protocol is important. So though she was, when I contacted her, they were in the middle of COVID and they had their own challenges. But she wasn't in our health board, so sharing our lived reality was going to be a challenge. The other thing I would say, and I would probably, if I was doing another one, is I'd rope some admin hours in, because there was a lot of sending the emails out, booking the rooms, changing the presentations, doing that were quite admin orientated tasks that were falling into clinical hours. And maybe some of it did need to be clinicians, because then you own it. You feel it's yours because you've worked on it, you've developed it. But I do think we would really have benefited from having possibly had some admin support in it. And I would probably say going forward, if I was doing another one like this, that was this multidisciplinary, I'd want some admin hours, because trying to coordinate and collate things is a challenge. So that would be my views. I don't know, I'd ask the team of what else they think would have been helpful or we should have done differently, other than not redeploy anybody in the middle of the project.
That definitely didn't help, but I think if we move on 12 months where we were this time last year, the better familiarity with IT and Microsoft Teams, Zoom, all the other formats, I think that probably was a hindrance in the beginning. But as we move forward and use that much more I think that's probably helped to be able to move things up a bit quicker.
I think the fact that we did the project as a multidisciplinary team helped. At different points, I think different people kind of took that lead and kind of did the pushing. It wasn't so much on one person to continually do that. I think the fact that it was kind of a shared responsibility, and at different points, different members of the team kind of did the driving and kind of kept it on track. Otherwise, I think it would have been easy to have come off track.
And I think there was a shared respect between us all that somebody could carry it forward. I know nursing particularly got impacted with redeployment, but they sort of entrusted us and respected us to keep it going, really, which has been huge.
How do we share this in Wales to prevent others from spending time developing similar projects and reinventing the wheel in Wales?
I think one of the things, Cardiff and the Vale are behind us in as much as they've identified that this was also something they saw an increased reporting level of through COVID-19. And because they know that we're doing the piece of work, I know that they're sitting holding off, waiting to see what we come out with, to see can they just do a lift and shift rather than investing a lot of time in having to develop all the things. I think that is about how do we promote across Wales, which is why I was talking about in my next steps about how do we share that exemplar stuff across the health board, outside the health board, in different events. It's also about saying, you know, we've developed these things, but they're not ours. You know, we went to Public Health Northern Ireland, had some lovely resources. And we approached our public health team to see if they would approach Public Health Northern Ireland for us to get to be able to use those resources. And they did that for us and managed to get it. And all that Public Health Northern Ireland wanted was that we put something on the back page of one of the booklets to say, you know, used in conjunction with the support of Public Health Northern Ireland. So it wasn't about reinventing things. It was about saying what's out there and can we use it? And can we just approach people to say, can we use your stuff? And I would say the same to anybody else across Wales. I mean, I don't think we would say, no, you can't use any of our resources, but we'd like you to have the courtesy of asking us, which would be so that we know that they're out there. And I think we do want to share it. And it'd be about how do we share that through things like the ADOTS and the DOTS forum to share sort of, you know, that stuff to other health boards. You know, my intention following today was to send the link for today's presentation stuff on to some of our nurse directors and other things within our own health board to say, this is where we've got to, this is where we're at. You know, please share, and, you know, we happily speak at, you know, or not necessarily provide a patient story, but provide a bit of a journey in one of, you know, the health board events of how you get there and how you get there through times of trouble, because it has been a hard time. You know, we've had staff who were redeployed to work in the field hospital, staff deployed into other roles from our project team. And poor Sue, our tissue viability nurse, is literally almost our last tissue viability nurse left in the health board at the moment. So her, you know, she was very engaged initially, but has had to trust us to get on and deliver it and get to an end point without her worrying about what are we going to say or do, and trust that we're going to have the knowledge and skills to have learned from what she's already imparted to us.